Hi, welcome to Renal Dose, small doses, large clearance. Today we're talking about acute kidney injury and chronic kidney disease. Traditionally, we think of AKI and CKD as two completely different entities, but are they really? Or are they separated only by time? See, in reality, many patients fall into an overlapping zone where it becomes difficult to clearly label the condition as AKI or CKD. Let me give you an example. A patient presents with a serum creatinine of 3. Can you confidently say whether this is AKI or CKD? Probably not. See, AKI looks something like this, and CKD looks like this. What you can see here is the creatinine rises over hours to days in AKI, whereas it rises over months to years in CKD. Another key difference is the reversibility. As you can see, in AKI the creatinine rises and then falls as recovery occurs. In CKD, the creatinine tends to progressively rise, reflecting a cumulative damage. That is why we use the term injury for AKI, something that is potentially reversible, as compared to disease for chronic kidney disease. Now, what exactly is creatinine? Creatinine is a byproduct of muscle metabolism. In terms of kidneys, it reflects the functioning nephron mass and not the total number of nephrons. Why so? Because when nephrons are lost gradually, the remaining nephrons compensate by hyperfiltration, maintaining the creatinine clearance for a long time. To understand this better, consider two kidneys, kidney A and kidney B. Now we know that every kidney is composed of the units of nephrons, and every kidney has millions and millions of them. Now imagine in kidney A, all these million nephrons suddenly stop functioning. Now compare this with kidney B, where the nephrons are lost slowly over time. So some are there and some are not. In the first kidney, the millions of nephrons that suddenly stop working, it is like workers going on a strike, so no work will get done. Now compare this to the other kidney, where the nephrons are lost gradually over time. The remaining will increase their capacity, they will hyperfiltrate and they will compensate for the lost function. Now this is like workers working in an understaffed department. Sure, they are working, but they are at the risk of fatigue and they are overworking. Now in first scenario, no work will get done. So these patients will mostly have oliguria and anuria. So AKI does that, and CKD till very advanced stages does not. With this, we move on to a key teaching points about creatinine, what we learned so far. So what we did learn is that it reflects the functioning nephron mass and not total nephron numbers. And you can lose 50% of nephrons and still have a normal creatinine. So it is a late marker for damage, but an early marker for dysfunction. Which brings us to this. A single value of creatinine without context of time is meaningless. So our patient who had a creatinine of 3, it tells us nothing unless we know the trend of that creatinine. So creatinine has to be in context of time. Now creatinine is an early marker of dysfunction, but is it that perfect? Let's look at this. This graph right here, it plots the daily urine output on the y-axis against time in hours on the x-axis. See, in the initial 48 to 72 hours, the urine output progressively declines, reaching an oliguric phase. During this period, despite falling urine output, biochemical markers like creatinine may still appear relatively stable, as shown in this graph. This is the lag phase of AKI. Beyond this phase, urine output begins to gradually improve, but the creatinine still does not improve significantly at first. So this period is known as the lag period. And this can sometimes be at 24 to 72 hours, which is about 48 hours in our patient. So what it tells you about creatinine as a marker in AKI? In short, it only tells you one thing. Creatinine lags behind. Creatinine does not rise immediately after kidney injury, there is always a lag phase, and hence early AKI can look deceptively normal. So in AKI, urine output tells the story early and creatinine catches up late. So is there any role of GFR in AKI? See, all the GFR equations that we do have right now use creatinine. But in AKI, the creatinine is changing very rapidly and there is no steady state. So which creatinine should we use? Should we use this one? Or should we use this one? Or any other creatinine for that matter? The short answer is GFR has no diagnostic role in AKI. The question that still remains is how to differentiate AKI from CKD. Now, to identify CKD, we need to identify markers of chronicity, right? But what are they? See, the most frequently used is the kidney size. See, the normal kidney size is 9.5 centimeters to 11.5 centimeter, and this number varies with the height. What we can do is we can put an ultrasound probe and we can measure the kidney along the long axis, and this dimension needs to be in this range. Again, height is in the context. In CKD, the kidney is losing nephrons, and we know that 85% of the nephrons lie in the cortex. So when the nephrons are being lost, the cortical thickness is being lost, and sometimes cortical thickness is even more important than the kidney length alone. So what is our takeaway from this? It is simply that small kidneys do confirm chronicity, but normal sized kidneys do not exclude CKD, and cortical thickness matters more than the length. Now, there are some examples where the kidneys can be normal sized, but they can still be CKD, and I need you to remember these examples because they're important. These are diabetic kidney disease, amyloidosis, multiple myeloma, HIV associated nephropathy, and autosomal dominant polycystic kidney disease. So, if you are suspecting CKD, you know there has been renal derangement for 3 months, but you see the kidney size is normal, you should look for these. How else can we identify chronicity? See, creatinine and filtration function is just one of the functions of the kidney. The other functions, most importantly the endocrine functions, will help us identify if the kidney disease is chronic or not. The kidney activates vitamin D and produces erythropoietin. These are the two most important endocrine functions of the kidney. Now, if the vitamin D is not activated, that means there will be no calcium absorption from the intestines. That will lead to low calcium. Now, low calcium will act as a stimulus for the parathyroid hormone. And now parathyroid hormone will try to get calcium from somewhere else, if not from the gut, and it will turn to the bone. So the calcium will be released from the bone and the bones will get weak. So in a patient of chronic kidney disease, you will have hypocalcemia, hyperparathyroidism, and weak bones, along with, of course, anemia because of erythropoietin deficiency. Now, do we get these markers of chronicity in all patients of CKD? And specifically when? See, if you divide the CKD in 5 stages, what you will see is the first 2 stages are usually asymptomatic and they do not have many markers of chronicity associated. You will only find hypertension and edema only if the CKD is of glomerular etiology in these 2 stages. When you move to the 3rd stage, you will find evidence of secondary hyperparathyroidism and anemia. And when you fall further to the 4th stage, you will find hyperkalemia, the tendency of which increases till the stage 5, and also metabolic acidosis similarly. Once the patient reaches stage 5, only then uremic symptoms do appear. So anemia, hypocalcemia, and hyperphosphatemia, these are late consequences of CKD. Their absence does not rule out chronic disease. Labs will support chronicity, but they will never define it. So what else do we have? Now let's look at a nephron microscopically. If you cut a section from a nephron, you will see tubules, interstitium, cells, and a poorly drawn extracellular matrix. Now with time, especially in the presence of proteinuria, the proteins enter the tubules. These proteins are mainly albumin and are absorbed by the tubular cells and then transcytosed into the interstitium. Now albumin is foreign to the interstitium, so the interstitium does not accept it. This triggers inflammation, and like all chronic inflammation, it ultimately heals by fibrosis. As fibrosis progresses, the interstitium contracts and tubules become dilated. Now these dilated tubules with protein in their lumen, they'll form what is known as the broadcasts. So the broadcasts are the results of chronic proteinuria, tubular dilatation, and interstitial fibrosis. And these broadcasts are highly characteristic of CKD. So to sum it up, the lab features that suggest CKD are proteinuria and cast in urine, along with anemia, hypocalcemia, hyperphosphatemia, hypovitamin D, and hyperparathyroidism. Now you won't get everything in all patients, but you will get some in many. And urine sediment is equivalent to renal auscultation, so do not skip it. Now why is differentiating AKI from CKD so important? Because the management is completely different. If your patient has AKI, the cause can be in the kidneys or it can be in the system. The most common systemic causes are hypotension, shock, decreased blood volume, sepsis, drugs like ARBs, NSAIDs, antibiotics, or infections. And if the cause is in kidney, it can be thought of as blood vessels, glomerulus, tubular interstitium, or obstruction of the pelvic ileal system. In blood vessels, if the involvement is in large blood vessels, it can manifest in the form of renal artery or vein thrombosis. Or it can be in the smaller blood vessels manifesting as thrombotic microangiopathy. Or it can be further smaller vessels in glomerulus manifesting as glomerulonephritis. So when you identify the site of involvement, only then you can treat the involvement. So AKI management depends entirely on the cause-directed therapy. Now contrast this With chronic kidney disease, the causes are not that varied and you cannot do much immediately. So, in CKD, the management principally involves addressing the cause of CKD, preventing and slowing down the progression of CKD, and supplementing the hormonal deficiency associated with CKD, such as erythropoietin and vitamin D. So, differentiating between AKI and CKD becomes important because your diagnosis changes the dialysis timing, biopsy decisions, and long term planning. Also, it gives you and the patient a better idea whether the condition is reversible or irreversible and what efforts it requires from your part. So, calling CKD as AKI will delay preparation, calling AKI as CKD will delay recovery, and getting it right is what matters. Always remember, creatinine tells you the number, time tells you the truth. This is Renal Dose. Thanks for watching. Small doses, large clearances. Let me know in the comments what topics you want me to cover next. Thank you.